Beta blocker and calcium channel blocker toxicity with Brash syndrome. Authors Niket Shah, Kevin Wattad, Andrew Kim, Adolfo Salazar, Sandeep Banga. Disclosures: no relevant financial relationships. Introduction. Brash syndrome is a relatively new term involving a vicious cycle that may occur when a patient taking AV node blockers develops bradycardia, renal failure, AV blockade, shock, and hyperkalemia. It can, it can have a variable presentation ranging from asymptomatic bradycardia to multi-organ failure. Here we present a case of life-threatening Brash syndrome caused by diltiazem and metoprolol prescribed for atrial fibrillation. Case description: a 75-year-old female with past medical history of paroxysmal atrial fibrillation, chronic obstructive pulmonary disease, heart failure with preserved ejection fraction, stroke, and squamous cell carcinoma of the left lung presented to the hospital with 1-week history of shortness of breath. She was recently discharged on diltiazem and metoprolol after an admission for heart failure exacerbation and new onset atrial fibrillation with rapid ventricular response. On admission, she was bradycardic, hypotensive, and hypoxic, with leukocytosis, hyperkalemia, and acute kidney injury. Imaging was suggestive of pulmonary edema. All AV nodal blockers were stopped, and calcium gluconate, atropine, epinephrine, and glucagon drip were initiated before she was transferred to the intensive care unit. The following day, she went into AF with RVR with hypotension that responded well with digoxin. Eventually, diltiazem was resumed, providing better rate control. Diuresis was started given associated heart failure. She became hemodynamically stable, subsequently moved to the floor, and discharged with a follow-up appointment with cardiology. Discussion. The accumulation of AV nodal blocking agents such as beta blockers and non-dihydropyridine calcium channel blockers, along with hyperkalemia due to renal dysfunction, leads to bradycardia even at therapeutic drug levels and hyperkalemia. In turn, bradycardia causes decreased cardiac output and can manifest as circulatory shock, which leads to kidney hypoperfusion and worsening acute kidney injury. This vicious cycle has been recently described as Brash syndrome. Given the complex pathophysiology and multiple mechanisms involved, patients can have a very nonspecific clinical presentation. Patients should be stopped on all AV nodal blocking agents when Brash syndrome is suspected. The initial management involves treating the underlying cause of beta blocker and calcium channel blocker toxicity, along with treating hyperkalemia and starting supportive measures. Calcium gluconate and other anti-hyperkalemic measures should be started immediately. For bradycardia and shock, atropine and glucagon, if beta blocker induced, can be initially started. Due to its chronotropic and inotropic effects, epinephrine is the drug of choice in treating bradycardia and improving renal perfusion. Our patient had a mild response to atropine for which glucagon and epinephrine drip were started with eventual improvement in hemodynamic status. Conclusion. Brash syndrome is a synergistic process that can lead to a devastating outcome, but it's a relatively overlooked syndrome. Early recognition of the constellation of clinical findings as a syndrome may improve patient outcomes and help avoid unnecessary interventions only focusing on each problem. When suspected, it's essential to discontinue AV nodal blockers early and give supportive measures for other triggers such as shock and hyperkalemia.